Yes, it's 4 o'clock. I think we can start our webinar today. Welcome to everybody. My name is Wolfgang Miesbach from the University Hospital in Frankfurt, and thank you for joining us for this EAHAD webinar. Maybe you know that the European Association for Haemophilia and Allied Disorders is a multidisciplinary association of healthcare professionals. And its members include hematologists, internists, pediatricians, nurses, physiotherapists, psychologists, laboratory scientists, and researchers from across Europe. And several working groups are working to improve care for individuals with hemophilia and other bleeding disorders. Now, today we speak about gene therapy, and gene therapy may present a paradigm shift in care for people with hemophilia and will also have an impact on the traditional setup of hemophilia treatment centers. Therefore, it's my pleasure today to welcome some chairs and members of different EAHAD working groups at this webinar speaking about their role in gene therapy, and it would be interesting to learn if their role would change and how it would change. Next slide, please. So this is a short overview about today's program. I would like to give a very brief introduction into the structure of hemophilia centers and the challenges we see with gene therapy. Since the next talk will be given by Greta Mulders. Greta Mulders is a nurse practitioner and study coordinator who has worked in hemophilia and bleeding disorders care since 2003 at the Department of Hematology at the University Hospital of Rotterdam. As a nurse practitioner, Greta Mulders is dedicated on her focus on patient care, multidisciplinary innovation, and nursing research. Greta is also a board member of the Dutch Association of Hemophilia Nurses and a member of the Advanced Nursing Forum of the Erasmus Medical Center in Rotterdam. The next talk will be given by Paul Mclaughlin. Paul Mclaughlin works as a clinical specialist physiotherapist in hemophilia at the Catherine Dormandy Hemophilia Center and Thrombosis Unit at the Royal Free in London. And his clinical interests are assessment and management of chronic musculoskeletal pain in hemophilia, lower limb biomechanics, and manual therapy. His main research interests are the effects of exercise on muscular pain, pain management strategies used by patients, and the use of patient-focused outcome measures. Then we have a talk given by Dr. Gaby Golan. Dr. Gaby Golan is a senior medical and clinical psychologist at the Tel Aviv Medical University. One of his main interests is the effect of the different treatment options and gene therapy. And finally, the panel will be completed by Dr. Steve Kitchen. Dr. Steve Kitchen is currently the head as lead clinical scientist in the Department of Coagulation at the Sheffield Haemophilia and Thrombosis Center in Sheffield, UK. He also serves as a scientific director for the United Kingdom National External Quality Assessment Scheme for blood coagulation and director of the World Federation of Haemophilia International External Quality Assessment Schemes for blood coagulation. And finally, we hope on a very interesting discussion between the panelists on the role and coordination of the multidisciplinary team in gene therapy. And we would like to welcome you to put all your questions you have in the Q&A forms that we have after the talks, time to answer your questions. Now, the next slide, please. Here are my disclosures. Very briefly, here are some challenges of gene therapy we used to learn from clinical trials in gene therapy. So this is about the pre-treatment period, the selection of patients, selection criteria, motivation of the patient, until the patient informed consent. And then the preparation, storage, and administration of gene therapy, probably the less complicated task, can be done in an outpatient department. Before and after treatment, several laboratory measurements are necessary. Coagulation factors, immunological parameters have to be measured several times before and after treatment. And then the most important part of this gene therapy will start the follow-up period, where it should be decided to change and to stop as a prophylactic treatment regimen with coagulation factors, and when to start and taper and stop immunosuppression. And all of these steps have to be communicated and coordinated between the team members of the hemophilia centers and the patients. Next slide, please. And it's probably clear that in very few cases, one hemophilia treatment center will be able to carry out all the different tasks related to gene therapy. Probably more useful will be the distribution of the functions between different hemophilia treatment centers and also maybe between different countries. One possible model for this is called hub and spoke model, and this has been the topic of the last webinar. But next slide, please. Now let's dive in the multiple roles of the member of the hemophilia center team in gene therapy, and also to examine how effective communication will support an individualized approach to this still experimental care. Some of these roles are very briefly outlined here, but of course it would be now much more interesting to hear and to discuss these roles with our panelists today and now in this live webinar. And the first talk will be given by Greta Mulders. Greta, please.
So good afternoon, everybody. Thank you for the kind introduction, Professor Miesbach. Yes, I'm one of the nurses who is going to talk here in this webinar, and it's a really honor to have a nurse on board. And additional to what Professor Miesbach said, I'm also one of the members of the EAHAD Nurses Committee. And this special committee, Nurses Committee, is the aim of this committee is to improve the quality of care for people living with hemophilia and allied bleeding disorders throughout Europe by promoting nurses as members of the multidisciplinary team, both in their role providing clinical care as engaging in scientific research activities. So the treatment with the recombinant factors still remain the standard of care in hemophilia. However, they pose a challenge to treatment adherence because most of them have a short half-life. And but we have also extended half-life factors. This common solution for patients, which increases this half-life to 96 hours. So prophylactic treatment is the optimum therapy as it prevents joint and muscle damage and allows the child or person with hemophilia to have a normal quality of life, and dosing depending on the weight of the patient. The age and the bleeding phenotype should be considered when it comes to dosing adjustments. On-demand treatment is used in patients with moderate to mild hemophilia. Now We have also another therapeutic approach for hemophilia A, and that's the replace of the cofactor function of a factor 8A with an antibody that would serve as a bridge between factor 9A and 10. Emicizumab has the main advantage of being administered subcutaneously, and it's more easy tolerated by patients. So with this all new treatments, and I'll talk to on gene therapy in a while, the role of the nurse is focused on treatment and coordinations of care, education, instruction, and adherence. Nurses are reviewing data on treatments on logs and having communication with patients in various ways. There are special apps are being used in hospital to be accessible in all times for patients. And nurses are also the first in line for patients' questions and remarks and need to act on that. So how do we get our patients as high as possible in quality of life measurements? Trying to be present and support in choices during sport, career, and lifestyle is very important. And especially in the adolescent phase, we sometimes see some difficulties. As nurses, we have to find out more strategies and new strategies to help and support our patients. And sometimes we have to think of something new. So specialist nurses are involved in providing direct clinical care, education, support, and self-management for patients and their families. Bleeding disorders can significantly reduce patients' health and quality of life, and nurses have an important role in providing psychosocial support and assistance during lifestyle adjustments. Nowadays, more and more articles of nurses are being published about these subjects. Oh, sorry, I'm going too quick. So like many people with long-term conditions throughout day-to-day self-management, people with hemophilia become experts and partners in their own care. As such, they should be regarded as a distinct core member of the comprehensive care team. They, and also their parents or caregivers or partners, should be involved in decision-making about their care, which should reflect on their preferences, values, and personal experience to ensure their concordance with short and long-term management plans and choices in treatment. When there is a choice for gene therapy, we have to inform them very carefully. And as a multidisciplinary team, we have to be aware that all expectations are being discussed before the choice of gene therapy. So we have to realize and we have to explain patients it's not a cure. And there are still some issues to be discussed. There are a lot of clinical managements, and there are also potential risks, like the evaluation of liver enzyme and also the use of immunosuppressive and his side effects. How the genes transfer really works and how it will be administered has to be explained, and also the level of clinical follow-up is required to explain. What is also important in the first interviews you have and the first consultations with patients is to filter out where did they get their information. There's a lot of information on social media, but are they correct? Are they really real? So filter and make patients understand gene therapy is not an event, but it's also a process. And we have to mind all patient steps also in this information phase. So when people choose for gene therapy, we have to explain all the time and educate. And when the administration is coming in the hospital, it's a special day for patients, and it's really quite intense. And when the patient is coming, then we have to inform and explain the procedure of the day. And the nurse has to be prepared and available all day, and the coordinator of the day. The presence of the physician is required during the hour of infusion. And afterwards, the patient have to know their trial journey. So how many visits, why they have to be ultrasound, and we have to adapt on working schedule of the patients sometimes. Just start also earlier when with the checkups when the patients want to arrive at the hospital a little bit early from work. And we have to involve also the partner and the caregiver. They have also a say in the choice of gene therapy. Also, it's very important to inform about the other requirements, like the use of appropriate barrier contraception during sex until the vector is cleared of the sperm, and also inform patient about their alcohol intake, and that we are as a nurse available at all time for questions or doubts. So after moving further after gene therapy, that's a huge transfer to different landscape and opportunities for patients with hemophilia. Patients note that there is more room and space in their head for other things in life. Still being born with a severe type of hemophilia, it takes time and renewed trust in their own mind and body to face activities, injuries, and just a simple regular check at the dentist can bring up doubts. So giving confidence is one of the main issues in providing support. And people change to a mild hemophilia phenotype are less affected in their condition and attend clinics less regularly afterwards. And this makes them more difficult to engage and less practice it that managing bleeds when they occurred. Nurses need to engage with these patients differently, and this requires psychosocial skills such as goal setting and motivational interviewing. Engaging with these patients also involves patient-centered approaches, such as increasing their involvement in decision-making about their care to improve their disease management skills. And this is shown to improve adherence and health outcomes. So in summary, the transformation of hemophilia from fatal disease to a manageable long-term condition is also changing the role of the specialist hemophilia nurse. So hemophilia care is evolving, and as a result, the hemophilia nurse is likely to become less clinically focused and have a greater emphasis on psychosocial support, including motivation, shared decision-making, support, and self-efficacy for patients. So hemophilia nurses coordinate and provide comprehensive care. As models of hemophilia care and management evolve, their role is changing to include more psychosocial care as a member of the multidisciplinary team in a hemophilia treatment center. Thank you for your attention, and I will give my hands to the physiotherapist in this team. Thank you.
Hello, everyone. Thank you very much, Greta, and thank you to Wolfgang for the kind invitation to present to you all today on this webinar about gene therapy. And I'm really pleased to be able to present the role of the physiotherapist for people undergoing gene therapy. My name is Paul Mclaughlin. I'm a clinical specialist physio based at the Royal Free Hospital in London. And we have been doing gene therapy for trials now for quite a few years. And so this is really just an overview of our experience that we have had really with how the physios become involved in that patient journey through their gene therapy. So today I'm going to give you a brief overview of sort of the musculoskeletal health issues in people with haemophilia and where gene therapy may sit in that. And a bit of a discussion around how gene therapy is really just more than a change to the actual bleeding disorder. I think Greta's touched on it really nicely there, but it's a change to the person and sort of their experience of their life going forward. And really how we as a multidisciplinary team, and certainly the physiotherapist, can help support the biopsychosocial needs of those undergoing gene therapy. And I suppose some questions for us to consider about what a future post-gene therapy may look like for those continuing to live with the musculoskeletal complications of their life lived with haemophilia before gene therapy. So physiotherapy and haemophilia, I think there's no real argument to be said that it, for comprehensive care, and for those that have lived and are living with multiple joints affected by haemophilic arthropathy bleeding, that the role for us has been extensive and arguably over the developing years with the development of better treatments, that role has actually changed for us depending on the age of the individuals and their history with treatment. I'm sure many of us have many patients in our clinics where we see that for those that have in sort of middle adulthood, 40s, 50s and 60s, they're currently living with quite a few joints that are affected by haemophilic arthropathy. They're most likely living with some functional limitations as a result of that arthropathy. And they may or may not be living with chronic pain either associated with the arthropathy or even with prophylaxis, they may still be experiencing breakthrough bleeds or difficulty discriminating between the beginning of a bleed and sort of a flare-up of their arthropathy. And within that treatment cycle and that treatment development, gene therapy really here now is the pinnacle of where we have been and where we are going with treatment. And whilst gene therapy can obviously have a significant change to the bleeding disorder, it doesn't change the presence of the haemophilic arthropathy. And I think that's really where I, as a physiotherapist, and certainly I think the multidisciplinary team are mindful of there's an expectation effect with obviously receiving gene therapy from a haemophilia perspective, but it's also about the sort of emerging expectations of what could a person be able to do if the risk of bleeding was minimized or eradicated with gene therapy. And so there is this sort of underlying sort of psychological concern or worry around sort of the motivation or the ability to be able to be active with their haemophilia and their joint disease. I think one of the biggest roles I see for us as physios is actually really evaluating and working with people on their physical literacy. Physical literacy is as a term or sort of a notion around what it is to be confident, to be active and confident to move. And it's been sort of described as having sort of movement competencies. So actually having the ability and the knowledge how to move, tactics and strategies of movement. And so if you imagine that's a strategy of movement is that if you have a painful ankle or a stiff elbow, that you will have a different strategy to move in regards to walking up and down stairs or feeding yourself or putting on a shirt. There's the motivation and the behavior skills of movement. If you have pain, and every time you move with your painful joint, your motivation to be more active may actually be affected. And then there's the personal social attributes of movement, what it is to be active in your household, in your community, in your society, within your family, the requirements for your work, your job or schooling. All of that can be pulled into this idea of physical literacy and what it is for a person to be confident, to be active. We know that a life lived with haemophilia, a life lived with bleeding and the ongoing issues with joint disease actually can influence negatively physical literacy in regards to how aware someone is about what they can do or what they're willing to do. Health literacy, on the other hand, can be really defined as sort of a personal health literacy and organizational health literacy. Personal health literacy is the degree to which individuals have the ability to find, understand, and most importantly, this term, use the information and services to inform the health-related actions for themselves. The difference between that and organizational health literacy is that organizations, it's how organizations equitably enable individuals to find, understand, and use that information. And that for us is really, really important as healthcare professionals. And I think we talk about health literacy in regards to prophylaxis and management of haemophilia and seeking healthcare services. But actually, I think this is a really important idea now in a post-gene therapy world in regards to what the previous experience that person has had with physical literacy and health literacy will change and is changing. And it is up to us as professionals to enable them to find that process and find that movement through to the next phase of their life in this sort of post-gene therapy abilities. Because I sort of see gene therapy as a transition across the disorder and therefore a transition across the embodiment of the self and the person living with that gene therapy and everything that that brings. With the gene therapy and the life lived with haemophilia, there will be previous experiences and fears and beliefs and expectations, certainly around the ability to exercise, the expectations of exercise and movement, what it is to be active, what it is to be fit, and the sort of, there may be for some negative connotations around fear around certain movements or exercises because of previous experiences, negative experiences with bleeding. There will be evolving physical goals. So actually, if gene therapy has a positive effect on removing a fear factor or an anxiety factor around bleeding, and that bleeding really is no longer an issue, there may well be the sort of the surprise of wanting to do more, but not actually sure how to do more and how to be more active. And I think that's where physios really sort of play a key role. There may be many barriers to progress in this post-gene therapy phase. And you know, they're no different to many people sort of trying to progress through physical activity in their own world. But you know, there will be physical, social, environmental, psychological barriers to progress, and there may well be remaining fears around being active or the amount of work that is needed to sort of help along that behavior change and support somebody in that new phase of movement. We also have to consider the side effects of undergoing gene therapy and the sort of the side effects of medications that are taken alongside gene therapy, such as the steroids and things like that. And things like weight gain can have a negative effect on body image, but it also can have a negative effect on joints that are already painful from hemophilic arthropathy. And actually, if you live with chronic pain, and then you take medications to help your gene therapy, but actually they then have a negative influence on your sleep, it is really important that we as teams begin to understand that perhaps somebody's sort of physical activity and ability to move in that in-between period after gene therapy may well be affected by other issues that we may not necessarily see up front. And then, you know, as the sort of the life beyond gene therapy evolves, this idea of having pain and joint disease, but actually having no bleeding, and actually beginning to then work with people to work out other ways of thinking and evaluating their own body. And actually, if it is not a bleed, what is it? And if it isn't a bleed and it's painful, what can I do for myself to help that? And what do I need to seek help with? And I think that that will not go away with gene therapy, but it just changes and may perhaps remove the issue or the fear of bleeding influence and joint pain. And then there's this underlying thing around unmet expectations. And the unmet expectations may well be from the gene therapy perhaps isn't as successful as someone wants it to be, but also there may well be sort of a negative expectation around what their physical being will be after gene therapy. And we have to be mindful of that the gene therapy may improve and correct the bleeding problem, but it may not be as easy to sort of work with the joint disease that's already there, and for many that are going through this process. And these are some questions really that are beginning to sort of come up now that we've had a few years of some people who've had success with gene therapy and are living with a, rather than a severe phenotype, they're now living with a sort of mild phenotype. Can multi-joint arthropathy be managed locally if bleeding risk is not an issue? And this, perhaps begins to challenge the idea of comprehensive care, and begins to challenge the idea of that lifelong care of haemophilia centres, and actually what can and needs to be managed in a haemophilia centre, and what perhaps after gene therapy may not need to be managed in a haemophilia centre. There's this risk of declining factor expression, and we don't know that until many years from now, but there will be perhaps added complexity of living with a mild haemophilia, but actually living with widespread joint damage. And that then may continue to add to where we can't be 100% sure that there may not be any bleeding if someone doesn't have a high enough level. And again, will comprehensive care be necessary? And these are all questions that will, not to be answered now, but maybe something to think about. And then there's the trial conditions to real world conditions. The follow-ups, as I said, the side effects and the medications, and the sort of the expectations of a new normal with no bleeding. And I think we as a multidisciplinary team are responsible to help these people navigate their life now post gene therapy. And different people will need different things. And so some may want more physio, some may want more psychology, all will likely need to be working with the nurse. So it's just really, the idea and the advantages of having an active MDT, identifying potential problems up front so that there's a plan in place for when this comes around. Gene therapy is an amazing possible future for some people. And the support that we offer as a multidisciplinary team should encompass all aspects of that person. And I think certainly as a physiotherapist, the supported behavior change around the evolving physical goals, exercise goals, physical activity goals is something that should be embedded in moving forward in these services. And really this is to enable the best physical condition possible that person wants to live. So thank you very much for your time. I will now finish up and pass on to Gaby.
Hello, everybody. I don't know if you see me. I hope so.
Yes, we can see you and hear you, Gaby.
Oh, that's good. Okay. Second. Okay. My name is Gaby, and I'm a clinical and medical psychologist. I work in the Israeli National Haemophilia Center in Israel. And I'm also a member of the psychosocial committee of the EAHAD. I'll talk about the psychosocial aspect of the gene therapy. And I was very, very happy to hear that also the nurse and the physiotherapist emphasize the effects of psychological aspect on the gene therapy. Now, when we want to check who is candidate for gene therapy, we have to, prior to the gene therapy, we have to communicate with the patient and to find out some very important issue. The first one is their motivation to go through this procedure. This is very important to find out how much motivation he has and what are the motivations, because sometimes the motivations are not clear, sometimes the motivations are not proper, sometimes he doesn't know why he is doing it, and it's very dangerous to go through this complicated procedure without the proper motivation. And the degree of their compliance, it's very important because they have to go through many tests and to check the side effects of steroids and so on during the 5 or 4 years of this treatment. So we have to check whether they think that they will get this gene therapy in one one time, and then they will disappear from the center. The mental status, this is very, very important, because if a person is in depression, this could be very risky for him, especially with all the steroids he will get during this procedure. If he's paranoid, just to try to imagine what will happen to someone who is paranoid. I mean, it means that he thinks, he's afraid that someone wants to do something to him, and someone puts something in his blood, in his veins, in his body. This could be very dangerous for this patient. Whether the expectation of the treatment are fit the reality. Some of them think that they'll get this treatment and immediately they'll not be with hemophilia, and they will not have to be in any connection with the center, the treatment center, and it's, of course, it's not real. Now, what are the aspects of the psychology? Since the patient was born, his personality was built around the hemophilia. It's like you can imagine like a tree that was raised or built around a stone, a huge stone. Now, if you take this stone, okay, what will be with this tree? And all the hemophilia, all they know, since the minute they know, they're aware of their personality, their identity, their hemophilia, they know that they have hemophilia. They are the hemophilia. So now what will be when they will not have the hemophilia? What will happen with their personality? It's a huge change. And when they execute the gene therapy, they say that they take the hemophilia out of their body, but not necessarily out of their personality. And it's a huge question when you meet someone, now after you've gone the gene therapy, are you hemophilia, post-hemophilia? What you are, you're regular man? And what about the past? Okay, are you stop being hemophilia? How to adjust to the new situation? For example, now we don't give this treatment to children or adolescents, but for children and adolescents that we work with, a lot of times they say that I'm with hemophilia, I'm very unique. Now, if we take the hemophilia out of their life, what is going to be with them? And the difficulty of their identity, a person with hemophilia, ex-hemophilia, or just a person. Trying to get used, not being special. You know, usually when someone is with hemophilia, even if he's an ordinary man with nothing special in him, when he's with hemophilia, he's very unique, very special to everybody. If in society, at work, we'll say, I have hemophilia, in a couple, then he's very special. Now, what will happen if he is not with hemophilia again? How to adapt to the new situation? Like the dilemma whether to tell a friend or girl that you want in a date. They said, will he say, I have hemophilia, I had hemophilia, I'm not with hemophilia anymore. Feeling that come in touch with hemophilia center, you know, the physiotherapist talked about the pain that you'll have in the joint, but without bleeding. Now, will he come to the center after he has this treatment? Will he meet his physiotherapist? Because he doesn't have hemophilia anymore. So it's like taking him out of his home and family. And an anxiety of the complication due to the common memory, you know, of the treatment, like during the 80s, there was a new treatment of factors. It was amazing. And then we found the HIV and the HCV complications, and people were died. A lot of people died from this. So there is a common anxiety, like we know that the gene therapy is okay, but what if? What if? Now for the future, there are some questions. Knowing that their daughters are going to be obligatory hemophilia carrier. So you don't take the hemophilia out of his body totally, because you will have this gene in him. What about the future? We don't know how much this therapy will last. Whether to keep the factor just in case, and some of them are keeping the factor just in case they need it, so they're not sure that they got the hemophilia out of the body. Fear from possibility of one day they'll become hemophiliac again, and it is a very crucial issue because, you know, since the moment they realized the world, but since the moment they realized who they are, their identity, they know that they have hemophilia. It's very complicated, but they get used to this. But after you take the hemophilia out of them, it will be very, very difficult for a lot of them to become hemophilia again. Now the conclusions. It is very important to set inclusion and exclusion criteria in order to screen the patient that are candidates for gene therapy, about their personality, expectation, motivation, and compliance. I'm not sure that we have this today, and I think it's very, very important to do it, to involve the psychosocial team before the treatment. The patients going through this procedure must get psychological support before, during, and after starting the treatment. It could be personal, but I prefer to do it in a group, support group. They want to have this, but usually we don't do it. The psychologist team must be involved on all the stage of this with other coordinated MDT. Thank you very much.
Fantastic, thanks very much. So I want to thank Wolfgang for the very kind invitation to participate. I especially want to thank EAHAD for putting on the webinar, and in particular Angelos in EAHAD. Angelos is the IT expert who is making this happen smoothly. When the faculty gathered just before we started, everybody was successfully able to share their slides, apart from me, which either means my hospital is not very good at IT, or it means I'm not very good. You have to be the judge. So I will have to keep asking for slide advance. I apologize for this. So it's been a very interesting time to be working in haemophilia laboratories. As you know, we've had many issues related to laboratory assays in relation to all of the exciting new developments we've seen over the last 5, 6, 8 years. Extended half-life, factor 8, factor 9, non-replacement therapies, great advances for patients, but bringing with them some important laboratory issues. It's never been more important during this recent era to understand things about laboratory assays. And maybe it would have been nice if the advent of gene therapy took away, let's say, laboratory assay issues, but unfortunately that's not going to be the case, as we'll now discuss. Next slide, please. So my disclosures, and the next slide, please. So I think if I've looked correctly at the attendees and the feedback received from EAHAD, I understand that many of the participants don't come from a laboratory background. So I wanted to just say a few words about one stage and chromogenic factor assays. These are words that we in the lab use quite a lot, and have been particularly used again during this era of extended half-life factor 8 and factor 9s. So one stage assay you can see on the left of this slide. It's a bad name. It's a name which was attributed to these tests, gosh, 70 years ago or more, And it's really rather a strange name because it's not a test which involves one stage. It's got several stages. The autoanalyzers in labs make a dilution of the sample. For a factor 8 assay that's shown on the slide, the analyzer adds some factor 8 deficient plasma. That contains all of the clotting factors, but no factor 8. We've made a mix. The only factor 8 in that mix is coming from the diluted test sample. We add an HTC reagent, we incubate, we get some contact activation, some activated factor 11. Then in a separate step, another stage, we add calcium and we time the clot. Lots of different versions, 20 plus different APTT reagents, many different analyzers, lots of opportunities to create differences between different reagent sets. And then on the right-hand side, you can see a chromogenic factor 8 assay. Same analyzers as for one stage, dilutes the sample, that's similar. Add some reagents, factor 10 and other reagents, everything that's needed to generate factor 10A, except no factor 8. The only factor 8 comes from the test sample. More factor 8 in the test sample, more 10A generation. We add a substrate, the 10A chops away the substrate, cleaves it and releases color. So on the one hand, one stage assay, timing the clot, in the chromogenic assay, monitoring color development. Chromogenic and one stage factor 9 assays, very similar to these, we just change the reagents a little bit. So just keep this in mind as we discuss in the tests and their results. Next slide, please. So this is a slide related to one of the factor 8 gene products, gene therapy. This is the biomarin product. And I've used this example because there are more data in the literature on this. This is a little bit ahead of some of the others, but the evidence that we've seen so far suggests that we expect to see similar relationships in the other factor 8 gene therapies. And what the slide shows is a series of samples from different patients in the trial, different symbols for each patient, 9 different patients, and a number of points, assays, a number of samples from each of those patients. And the central solid line, this is the line of the same answer, the line of unity. Same result by one stage on the vertical axis or same result by chromogenic. And what you can see is that all the points to the left of the line indicating higher results by one stage assay. This is this like the other gene therapy products, this is a B domain deleted gene product. And here, as you can see, chromogenic factor 8 activity results much lower than one stage, on average lower by about 60%. So higher one stage, lower chromogenic. And what's really interesting is that those of you who've worked with B domain deleted concentrates of factor 8, Refactor-AF is one of the first of those. What we saw there was really quite the opposite relationship. So reversed. In that case, with that concentrate, we saw much higher results by chromogenic, about the same relationship, but the other way around. So it's a bit of a surprise when this came through. It means in the end that the factor 8 in these gene therapy products is not exactly the same as the factor 8 in concentrates. There are clearly some differences yet to be unraveled. Next slide, please. What about factor 9? Well, most of the gene therapy manufacturers working in the factor 9 gene therapy area have gone for a factor 9 Padua. So not the native factor 9 molecule, but a mutant form. And 9 Padua was first described as a spontaneous mutation in factor 9. It was identified during thrombophilia testing in Italy, in Padua. And interestingly, the factor 9, this 9 Padua with this particular mutation is 6 or 8-fold more active in one stage assays compared to wild type. So it's gain of function. It's much more active. Of course, that makes it an attractive candidate for haemophilia gene therapy. And again, at least 5 companies are using 9 Padua as their source. There's at least one that's not. Next slide, please. And there's been a number of these that's under trial so far. There is a comprehensive field study that's not yet published, at least not in the full article. It's been published in abstract form in previous ISTH conferences, and this is taken from some of that work. This slide shows factor 9 assay results in, this is the free line factor 9 Padua gene products. So one of the particular companies. And what it shows is the factor IX levels are different according to which assay is used. In light green at the bottom line are two different chromogenic substrate assays. And this slide shows the results in each of these different types of assay on the vertical axis compared to one particular one-stage assay. In this case, the Synthesil is a one-stage assay, and the company chose this. This was the test that was in use that's in their research laboratory. And what you can see in the one-stage assays, OSA, one-stage assays, is a number of different results according to which reagent set was used. So once again, differences between one-stage and chromogenic. Here we're seeing on average chromogenic results lower than one-stage, on average by 40%, but some big differences according to which type of one-stage assay was used. What you can also see on here is that the points are closer together when the concentrations are lower. So at the left of the lines, 10, 15, those kind of levels, smaller differences between different assays. When we get up to the level around 140, 150, then a much bigger difference according to the assay type. So we're seeing, again, big differences according to the assay. So we've got to keep this in mind when interpreting the results of such studies. Next slide, please. I think it's very encouraging that some regulators have taken the view that it will be important to have data on different assays in advance of those materials being licensed. So you can see on this slide some of the recommendations from FDA, and these were published a couple of years ago. In order to, let's say, get the accelerated approval, then there are a number of requirements. And what FDA is recommending is that the sponsors, the companies, should consider performing studies in different laboratories using the specific gene product. Could be from animal plasma or could be in transduced cells, but to do this and then run field studies to compare the results of different assays, one-stage coagulation, OC, and chromogenic substrate, CS. So OC, one stage, CS chromogenic. The companies, according to this guidance, should be performing such field studies. And I think that's would be most welcome. And I showed you one example in the previous slide. I've not seen much evidence of this from a number of the companies yet, but I hope we can anticipate seeing this in future. Next slide, please. So when we've got a difference, what does that mean? Which result should we be thinking? Which is the one that we should use? Which is the most relevant? Why are we seeing these differences? But when in the end, the most important information, as always, comes from the patient and the clinical outcomes. This will in the end tell us which are the levels in the lab test which are associated with reducing the bleeding risk, with reducing the bleed rate, with improving the efficacy. That's in the end what we require with those clinical outcomes. And these are underway with the companies, of course. Okay, we don't have huge numbers of patients yet, but that will in the end help us to understand which of the tests really is best correlated with the clinical picture. That's the most important information, I think. If we look at what's going on and what's the cause of these differences, then there are some laboratory-based studies to help us with this. So for example, in relation to the factor IX Padua issue that I mentioned, and this is a piece of work specifically related to the Freeline product, I suppose in the end, the other gene therapy products based on IX Padua will have many similarities, but will not in the end, let's say, be identical. So we have to also be aware of that. But this publication related to factor IX Padua, it's in press at the moment. They did some laboratory work that suggests the clue is in some of the lab reagents. And so I mentioned in the chromogenic assays that factor 10 is present. I showed on the slide an example of factor 8 chromogenic assays, but I think I mentioned in factor 9, it's very similar. And so there's factor 10 in the kit. How much factor 9 in the patient sample, active, how much is there, that influences the rate of 10 activation. But when you've got this much more active form, IX Padua, you get much more rapid activation of factor 10 in the kit. So it looks like the level of reagent in the kit is probably not optimized for factor IX Padua. And that would suggest that perhaps the results by chromogenic would be less likely to correlate with the clinical picture. We need the full information really from clinical trials to show this. And then when it comes to factor 8, there's a nice publication looking at the mechanisms, let's say, behind these assay differences in relation to the biomarine molecule. And what this study is fully published. You can see the reference at the bottom. Stefan Rosen is a lab scientist in Sweden. Actually, he's the lab scientist who invented chromogenic assays in a former life. Fantastic lab scientist. They did a nice study, again looking at the rates of activation in relation to the reagents, and what they were able to show that the factor VIII molecule in the biomarine gene therapy trials shows really accelerated, very much faster, in fact, to 10A generation in the test. So it's accelerated early, and this has an impact on the one stage results, elevating them, but not on the chromogenic assays. So there is a potential impact here related to the lab reagents, let's say. Okay, what they also went on to show that this let's say accelerated early 10A generation, it didn't in the end lead to a difference, an important difference in thrombin generation. So probably this was less important in the end in relation to the patient. So we need more data, but at this time, then it's clear that there are some implications of the lab reagents, let's say, that probably influenced the patterns that are being reported. Next slide, please. So I think in conclusion, we have to just keep this in mind, and our interpretation of assay results after gene therapy, this really does need to take account of the method and the reagents that's used. And of course, if in the end the payments or funding related to gene therapy are influenced by the levels in the patient as let's say a surrogate marker of efficacy, if that's the case, then it becomes really important that we understand these assay issues in order that it's fair play according to which lab tests are used, let's say. Thank you for your attention. I think that's my last slide.
Thank you so much, Dr. Kitchen, for this excellent talk, and also to all the speakers of this panel today for all your insights. So as a physician, I'm really very much impressed, and I think it cannot overestimate it, how important it would be to involve all of your skills and your ideas and what you mentioned today into each of these periods of gene therapy. So this was a great session today. I think we nearly have exceeded our time of 60 minutes. Maybe just time for one question from the chat. It's to you, Paul, regarding the follow-up period after gene therapy and the role not only of the physiotherapists, but also the role of ultrasound, so of joint ultrasound. Do you think this should be done regularly, and what would be the purpose of this?
I think if the clinicians are convinced that gene therapy is working and that the assays are saying that it is, and it may well be that if the patient is struggling to disassociate their internal sense of that pain feels like a bleed, my joint feels like it's bleeding, ultrasound can be very useful as a biofeedback to show actually there's no bleeding here, there's nothing to worry about, and it can be really nice to sort of just help decrease some of the anxiety around the difficulty with the sensations, because these patients have lived for years with their own internal monitoring system, and joint pain can often feel like a bleed pain, and gene therapy removes the bleeding, but it doesn't necessarily remove the pain, and so it just takes a little while for the brain to re-educate itself. So I think ultrasound can be useful for that. I think in joint health monitoring, I think perhaps in a post-gene therapy world, it may well be just to clarify things like synovitis should be decreasing and whatever. But again, then you're into synovitis exists with arthritis anyway. So then that's a whole other conversation around, is the synovitis because of arthritis or is the synovitis because of haemophilia? But that's a conversation for a different day, I think.
Yes, unfortunately, we have not the time for all the questions and to discuss it. But it's not our last webinar. We are planning some more webinars the next time. And maybe, Angelos, could you share the QR? That's great. So for me, it became clear that we really see a transition process in our patients after gene therapy. And it was very interesting for me to hear how this transition process can be accompanied by the multidisciplinary team. And thank you very much for your attendance. Please use this QR code and send us a feedback. Also, maybe if there would be some topics you would like to be presented with one of our next webinars. And again, I would like to thank all of our panelists for the excellent presentations and very insightful presentations. And I really hope that we would continue our work within EAHAD and within the EAHAD working groups to further develop some concepts for the pre and post gene therapy treatment period. I think it would be nice to have the QR code again, if this is possible. Great. And so thank you again to our speakers for the excellent presentations. Thank you, the audience, that you attended this webinar, and also for your interest and your questions. And finally, thank you very much, Angelos and Pascal, for your great preparation, organization. And from that on, I would like to wish you a very nice afternoon. Where are you now? And thank you very much again for your attendance. Have a nice afternoon, evening. Bye-bye.